Excessive daytime sleepiness, an overview. I'm Chris, physiotherapy student. Among the daytime symptoms related to sleep disorders, daytime sleepiness is one of the most disabling. This is a frequent reason for seeking medical care on an outpatient basis and sometimes in emergency care units. Excessive daytime sleepiness, or hypersomnia, can be conceptualized as difficulty in staying awake and alert with a greater tendency to fall asleep during the day unexpectedly or at inappropriate times. It is important to make clear that it is not always necessary for sleep to occur, but only this feeling of need for daytime sleep is enough, even if the individual manages to withstand the nap. Thus, daytime sleepiness is primarily a symptom and is directly related to a subjective interpretation. However, as we will see throughout the chapter, there are some strategies to standardize this assessment, whether with subjective clinical scales or with objective neurophysiological parameters. Patients living with hypersomnia suffer from a very heterogeneous group of syndromes and disorders. It makes this epidemiology very complex. There are several studies in association with age, sex, body mass index, work-shift, snoring, obstructive apnea, and among groups of specific comorbidities. However, the prevalence in the general population is little known and varies with the methodology used. The overall prevalence is estimated at around 4 to 20.6%. A recent prospective study of a Swiss cohort showed an incidence of 5.1% in a 5-year follow-up. Risk factors in this survey associated with the onset of hypersomnia were male gender, depressive symptoms, poor subjective quality of sleep, and moderate to severe sleep apnea. Some of the other risk factors also defined in studies of incidence are depression, sleep apnea, obesity, and diabetes. The recognition of hypersomnia becomes very important because it has already been defined that this symptom, in isolation, determines an increase in general morbidity and mortality. A 10-year prospective study of a large cohort showed a mortality of all causes has a ratio of 1.43, that is 43% greater chance of occurring in the group with daytime sleepiness. In addition to higher mortality, it implies economic and social losses. In this chapter, we will go deeper into the study of hypersomnia, especially in the diagnosis and recognition of its causes and available guidelines for approach and treatment. Diagnosis. Evaluation of patients with excessive daytime sleepiness is generally a clinical challenge. At first, despite being a relatively common complaint in neurology and sleep medicine clinics, the search for medical help in the face of symptoms is still restricted, and in most cases it is delayed. The reason for this is diverse and ranges from cultural issues and ignorance about sleep disorders, difficulty in accessing a specialized service, or even prejudices and dysfunctional beliefs in relation to the patients with daytime sleepiness. The initial step in the management of patients with daytime sleepiness is to better understand the complaint and to know how to precisely define it. During the consultation, at the initial moment, we can already see if the patient shows sign of drowsiness at that moment. Yawning, little motor activity, difficulty in attention, or even demand for coffee can be indirect signs for the diagnosis. During the interview, it is very important to assess whether the patient has daytime episodes, when he has difficulty staying awake, and how severity is functional impact, even in social, professional, or school spheres. It is common for the patient, in a simple directed question, to deny having daytime sleepiness only because he is already accustomed to the symptom or because of not taking daytime naps. But when properly assessed, it is evident that for several moments he has some discomfort related to the difficulty of maintaining himself awake. A distinction that must be made during the clinical interview is whether the patient complains of fatigue and apathy or really daytime sleepiness. Fatigue is referred to as tiredness, lack of energy, and exhaustion. It is usually induced by overactivity and release with rest. Daytime sleepiness is referred to as a decreased ability to perform tasks that worsen at rest or in monotonous situations and relief with sleep or nap. Some clinical scales support this subjective assessment of the symptom. The Epworth Sleepiness Scale is a self-administered questionnaire, a good alternative to quantify the sleepiness of patients with hypersomnia. It is an inexpensive tool, remarkably simple and quick to execute. The ESS has 8 questions that show routine situations in which the patient must rate the probability of falling asleep, in reference to the symptoms in the last month. Each of the questions is scored from 0 to 3, with 0 being no chance of sleep, and from 1 to 3 progressively greater chance of falling asleep. The global score ranges from 0 to 24. The higher the score, the greater the daytime sleepiness. The scores greater than 9 indicates that the patient has excessive daytime sleepiness. The Stanford Sleepiness Scale is also a well-established questionnaire for assessing daytime sleepiness, but it also provides little information for assessing outpatients. This scale assesses the patient's state of alert at a precise moment and the propensity to sleep in the momentary situation in which it is applied. The score ranges from 1 to 7. The higher the score, the greater the drowsiness. Scores greater than or equal to 4 show significant drowsiness at that moment. It can be used in a clinical context to guide patients with hypersomnia to better recognize and graduate their symptoms in order to avoid performing risky tasks when at greater drowsiness, thus avoiding work and traffic accidents. In addition to subjective assessments, it is possible, in specific contexts, to use supplementary tests to objectively quantify daytime sleepiness. There are 2 neurophysiological tests that provide important information for this purpose: the multi-sleep latency test and the maintenance of wakefulness test. The MSLT, multiple sleep latency test, is indicated for the investigation of patients with hypersomnia and is especially important for the diagnosis of narcolepsy and other central origin hypersomnias. MSLT is the multi-parametric analysis, EMG, EOG, and EEG of 5 naps performed during the day. The exam starts 2 hours after the end of the night polysomnography, and it continues with 5 opportunities of nap in a calm, dark, and silent environment. The patient is instructed to try to sleep. It is assessed whether the patient falls asleep before 20 minutes of recording, and if it happens, it is observed the first 15 minutes of sleep to assess the sleep stages reached in that period. The most important data used to the interpretation of the result is the mean sleep latency. That is how long it takes for the patient to start sleeping from the beginning of the record until the first time of sleep. The mean sleep latency of these 5 records is suggestive of EDS if it is less than 10 minutes. The lower the average sleep latency, the greater the patient's propensity to nap in monotonous situations. SMnPT is a neurophysiologic exam very similar to MTLS, especially in data collection, but it has some peculiarities. This exam is not largely used in the diagnosis of hypersomnia, but it can be useful in the clinical follow-up of patients, and it is used in the legal documentation of excessive daytime sleepiness in some countries for labor purposes or vehicular driving. The patient is monitored with EEG, EOG, and EMG of the chin and positioned comfortably in the bed, seated with indirect light in a quiet environment. In this case, the patient is instructed to try not to sleep. Latency, the sleep onset, is monitored within 4 14-minute opportunities, assessing the mean sleep latency. Once the patient is identified as having hypersomnia, physicians need to identify the cause of this symptom. From this moment on, we'll present the main causes of hypersomnia, organized in diagnostic groups with their particular aspects of epidemiology and management. Causes: insufficient sleep syndrome, chronic sleep deprivation. Insufficient sleep syndrome, which is named in the third classification of sleep disorders, or the chronic sleep deprivation, is the most common cause of excessive daytime sleepiness, especially in young patients. Although more prevalent during adolescence, when the need for sleep is greater, insufficient sleep syndrome can occur at any age and in both genders. In addition to daytime sleepiness, the patient may experience other symptoms such as irritability, difficulty concentrating and paying attention, distractibility, reduced motivation, dysphoria, fatigue, and lack of coordination. Secondary symptoms can become the patient's primary focus, making diagnosis difficult. In addition to the consequences directly related to daytime sleepiness, as already mentioned in this chapter, these patients add greater cardiovascular risk and higher overall mortality due to shortened total sleep time. For the diagnosis of insufficient sleep syndrome, complementary to the clinical interview with a usual sleep schedule during workdays and days off, a sleep diary can be requested, in which the patient records the subjective perception of a period of sleep and waking up time for a few days or weeks. Objective data can be assessed with actigraphy, which is the gold standard for sleep schedule analysis. Actigraphy is a recording through a movement sensor of periods of activity and rest, allowing the objective interpretation of sleep times and circadian rhythm. The treatment of insufficient sleep syndrome is based on a simple rationale of prolonging the total sleep time. Despite being a simple guideline, it is often difficult to perform due to poor patient compliance, especially when social conditions are unfavorable. Hypersomnia due to a medical condition. Hypersomnia, secondary to clinical disease, is also a diagnosis recognized by the International Classification of Sleep Disorders. There are several clinical or neurological conditions that are associated with daytime sleepiness: thyroid dysfunction, kidney and liver failure, hypovitamininosis B12 or D, severe anemia, Parkinson's disease, Alzheimer's disease, neuromuscular diseases, structural brain injuries, and head trauma are some examples. Patients may experience increased total nighttime sleep, daytime sleepiness, prolonged naps, or attacks of sleep during the day. Treatment of the underlying condition tends to improve the symptoms of hypersomnia. In the presence of residual symptoms, diagnosis should be reviewed, and the possibility of another associated cause for daytime sleepiness should be considered. Hypersomnia due to a mental disorder. Hypersomnia, secondary to a psychiatric disorder, can be diagnosed when there is an association between drowsiness and a psychiatric disorder. The diagnosis of hypersomnia associated with a psychiatric disorder can be a challenge because very commonly, the patient is intensely focused on the symptoms related to daytime sleepiness, hiding other psychiatric symptoms. Several psychiatric disorders are related to hypersomnia, but the most common are major depressive disorder and bipolar affective disorder type 2. In addition, somatoform disorder, schizophrenia, and personality disorders can be associated. Hypersomnia associated with the psychiatric disorders is more common in women than men. In patients with depression, the prevalence of daytime sleepiness is around 5 to 50%, according to the hypersomnia diagnostic criteria. Hypersomnia due to drugs use. The use of medications can also be a causative or worsening factor of daytime sleepiness. There are several classes of medications with sedative effects. Some are used for this purpose, hypnotic drugs, and others appear as an adverse effect. In patients with daytime sleepiness, it is important to assess whether they are using these drug classes: benzodiazepines, non-benzodiazepine hypnotics, antipsychotics, sedative antidepressants, anticonvulsants, opioids, and first-generation antihistamines. Dopaminergic agonists can also lead to daytime sleepiness, like sleep attacks. There is different individual tolerance to all of these medications, and some patients are more susceptible to severe symptoms even at low doses. Elderly and patients with altered clearance metabolism are especially sensitive. In addition to the use of medications, the use of some substances can also induce daytime sleepiness, such as alcohol, marijuana, and sedative teas. Withdrawal of stimulating substances and medications can also lead to rebound drowsiness. These can happen in abrupt cessation of the continuous and frequent use of caffeine and amphetamines. The treatment in this context will be directed to the reduction of dose or suspension of medication related to the symptom. The cost-benefit of the sedative effect should be evaluated in relation to the desired beneficiary effect with the medication. Whenever possible, evaluate other therapeutic possibilities. Hypersomnia related to a circadian rhythm disorder. Disorders of circadian rhythm are also common causes of excessive daytime sleepiness. Patients with advanced sleep phase, preferred sleep time earlier than the majority of the population, experience daytime sleepiness in the late afternoon or early evening, and the patient with delayed sleep phase experience sleepiness mainly in the early hours of the morning. The diagnostic tip is to assess sleep schedule, their regularity, and especially in most social-free periods such as weekends and holidays. More recently, a new phenomenon related to sleep deprivation is the circadian rhythm has been described, the so-called social jet lag. The social jet lag is a time difference between work days and days off. The phenomenon occurs when there is a difference in the midpoint of sleep, bedtime and waking time divided by 2, between working days and rest days greater than 2 hours. Several recent studies show independently higher cardiovascular risk and overall mortality in these patients. The treatment of daytime sleepiness in these cases is dependent on the treatment of the rhythm disorder. Guidance on the regularity of bedtime, searching for sleep schedule more similar to biological demand, and orientation on times of greater exposure to light can help with the synchronization of the circadian rhythm. The use of melatonin may also be indicated in the treatment of the delayed sleep phase. Hypersomnia due to a sleep disorder. Various sleep disorders can trigger daytime symptoms such as fatigue, daytime sleepiness, irritability, difficulty concentrating, and learning. Faced with a patient complaining of EDS and signs of poor sleep quality, the investigation should be directed towards sleep disorders, and if indicated, nocturnal polysomnography should be requested. Polysomnography is a complementary exam that registers several physiological variables during sleep: latency for sleep in minutes, latency for REM in minutes, total recording time in minutes, total sleep time in minutes, sleep efficiency in percentage, sleep stages, arousal per hour of sleep, apnea and hypopnea index, and oxyhemoglobin saturation, as well as body and limb movements. The registration of other variables can also be done depending on clinical needs of each clinical suspicion. The use of more complex neurological channels in EEG record, as well as more electrodes for capturing muscle activity in extremities or for detailing rheumatism may be necessary. Restless leg syndrome, periodical limb movement syndrome, sleep disordered breathing, rheumatism, and parasomnias are part of the differential diagnosis to be excluded. Obstructive sleep apnea is a common cause of daytime sleepiness. OSA associated with daytime sleepiness affects 3 to 7% of adult male population and 2 to 5% of adult women. Both sleep apnea and sleepiness secondary to sleep apnea are more common in men. This statistic equalizes when women reach menopause. Some symptoms act as a warning sign for the diagnosis. The most common are easily recognized, such as snoring and apnea. Other less classic symptoms, but very helpful in the diagnosis, especially when the consultation is carried out without the presence of companions, are nocturnia, dry mouth, morning headache, non-restorative sleep, night sweating, and sleep fragmentation. Hypersomnia of central origin. Excluding the differential diagnosis mentioned so far, there is a set of rarer hypersomnia named hypersomnia of central origin. Diseases such as narcolepsy, Klein-Levin syndrome, and idiopathic hypersomnia must be recognized, and the differential diagnosis must be remembered. These diseases lead to a significant reduction in quality of life, as well as a higher risk of personal and professional accidents. The delay in diagnosing these diseases is greater than 10 years, with a significant impact on the quality of life of these patients. Health professionals need to be well prepared and motivated to make diagnosis of rarer sleep disorders. Efforts by university circles have been made trying to reverse this scenario with continuing education on topic for patients and health professionals. Narcolepsy is a chronic neurological disease with very important social, personal, and family repercussions. Narcolepsy is characterized by excessive daytime sleepiness, characterized by short-term recurrent sleep attacks, fragmentation of night sleep, and other REM sleep phenomena such as cataplexy, sleep paralysis, hypnagogic, and hypnopompic hallucinations. First-degree relatives of narcolepsy patients have a risk of developing drowsiness of central origin about 20 to 40 times greater than normal individuals in the general population. However, a family pattern for cataplexy alone rarely occurs. Until now, narcolepsy does not have curative treatment. Symptomatic medications are prescribed with the intention of controlling the main symptoms of the disease. Non-pharmacological measures should also be taken with guidance on sleep hygiene, scheduled naps, physical activity, and routine activity regularly. Idiopathic hypersomnia is a sleeping disorder of unknown cause. The diagnosis is defined through neurophysiological evidence of daytime sleepiness, that is, average sleep latency in MLST less than 8 minutes and absence of REM sleep changes. Any other cause of daytime sleepiness should be excluded. Despite being a diagnosis of exclusion, patients with idiopathic hypersomnia have some characteristics that suggest the clinical condition. In general, they are patients with excessive sleepiness with increased total sleep time 24 hours a day. They present permanent sleepiness different from the sleep attacks characteristic of narcolepsy. Naps of patients with idiopathic hypersomnia are also different from those present in patients with narcolepsy, being generally prolonged, lasting more than 1 hour, and usually not repairing. Another symptom suggestive of idiopathic hypersomnia is sleep inertia. This can be defined as a prolonged difficulty waking up with a frequent return to sleep, irritability, difficulty in performing cognitive tasks, irritability, automatic behavior, and confusion. Autonomic symptoms have been reported, such as orthostatic hypotension, changes in thermal perception, and Raynaud's phenomenon. Treatment must have behavioral and pharmacological approaches, guidance to family members, and the use of stimulants improve the quality of life of these patients. Klein-Levin syndrome is a very rare disease, but a classic cause of recurrent hypersomnia, characterized by recurrent remitting episodes of severe EDS associated with cognitive, psychotic, and behavioral changes. The duration of the episodes is variable, usually around 10 days, and can last up to 3 days. The episodes have an evident functional impact. Common behavioral symptoms are hyperphagia, hypersexuality, coprolalia, and copropraxia. Patients commonly report a symptom of lack of realization, with difficulty in stating what is real or dream. In the intervals between crises, the patients do not present cognitive or psychiatric symptoms nor sleepiness. There is no specific effective therapy, and the treatment involves medications with different effects. Lithium carbonate and carbamazepine have been used with inconsistent responses to increasing crisis intervals. Usually, there are frequent spontaneous remissions with advancing age. Final words. Excessive daytime sleepiness is a common sleep complaint, and for its proper management, it is important to understand the groups of causes of hypersomnia to direct the medical interview, the physical and neurological examination, and the complementary investigation. We highlight 7 etiological groups to be considered: insufficient sleep syndrome, clinical and neurological diseases, mental disorders, sleep disorders, use of drugs or substances, rhythm disorders, and more rarely, hypersomnia of central origin. The treatment of hypersomnia will be directed to its underlying cause, and in specific cases where necessary, symptomatic treatment with the use of stimulants may be done. I'm Chris, physiotherapy student. Hope you enjoyed today's topic of excessive daytime sleepiness and overview. This is Chris, signing out.